Good afternoon, everybody. Welcome to SEVA VentRounds. Today is October 28, 2025. And although this is not really session number 100 because we have done more than that, but this is session number 100 going on YouTube. So regardless, it's pretty cool. And the next images that we have were donated to us, and I thought that it was worth it to look. And because it has two zeros or two O's, it goes with session 100. So it's pretty worthy. Remember, there's no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. And both Rob's and my conflicts of interest are deployed on the screen. Remember, these are recorded sessions, so just mute your microphones. If you want to talk, unmute them. We're happy to hear what you have to say, or you can use the chat function. We're monitoring both, and we're happy to interact with you. Remember, there is CRCEs as well as CME for you when the session is finished. So just from the SEVA knowledge perspective, I would like to just highlight, and this cartoon that Rob did years ago highlights the respiratory system with the respiratory airways, the respiratory system airways, and then this space which represents all the alveoli. And so you have the airway opening pressure here in red, and then you have the alveolar pressure here in blue, and then the pressure surrounding the alveoli, which is the pleural pressure. And this is useful for us to kind of outline what we consider to be a transmural pressure. So the pressure inside minus the pressure outside. So the pressure inside the alveoli minus the pressure outside, which is the pleural pressure, would be the pressure across, or transmural pressure. Now, if we have the ability to place a alveolar catheter to measure pressure inside the alveoli, and a pleural catheter to measure the pressure in the pleural space, that would give us the transalveolar pressure difference. And this is a common error in how people report these things, but this would be the transalveolar pressure difference. In reality, the way that we do this is we use the transpulmonary pressure difference, which is essentially the airway opening pressure, so here in red, minus the pleural pressure, which we rarely measure, and we use the esophageal catheter instead. So airway opening and pleural pressure. And that would give you the transpulmonary pressure. And in majority of static conditions, there's certain circumstances in which it doesn't. The transpulmonary pressure will be equal to the transalveolar pressure. So meaning when there's no flow and the valves are closed on the ventilator, these two will be very close. Rob, any comments?
Looks great. I like your color scheme.
Awesome. Wonderful. Well, you did it, and so we just highlighted here, so great job. I mean, this image, I think that it's from the booklet from Respiratory Care in 2006, but then it went to the book and whatnot. So really good job. All righty. So let's move on. And so this image that we're going to show you, it was a donation from Dr. Armando Rios in Mexico. And he sent me a series of images, a trove of cool images, but I really enjoyed this one for multiple reasons, and I hope that you enjoyed it. And I put another one just because I was so excited with the images that he sent. So today we're getting double for the price of one. So to start, just for you to be aware, this is a G5 ventilator, and so from Hamilton, and you can go ahead and write on the chat, what do you think is the tag for this mode? As you see it also on the screen by looking at the waveforms. There you go. And rapidly, the universe of mode starts appearing, and all of you in good fashion change to the generic name, the taxonomy, that tells us that even though the name has this S followed by CMB, which is the term that the company decided to put. It's the commercial name. We know that this is volume control, CMBS. And be careful, because this is something that we learned recently. If you see a plus sign after this, that turns into a completely different mode. So just be aware, if you see a plus sign after SCMB, that's not volume control CMBS. But what that stands for means that in this case, we're controlling the flow, and it's a constant flow. And I will just mention, because this causes sometimes distress in our team when they see the flow waveform, and as you can see clearly here, instead of looking like a square, it has this piece missing. And then this one, instead of being a square, looks like a little bit of a jaggedy line, and this one is missing a little piece. But that is because the flow sensor on this ventilator is at the Y. And so you will see whenever there is PMOS or other items, you will see the flow not be a perfect square, because there's movement across that flow sensor at the Y of the circuit. Rob, comments?
Yeah, there's movement across the flow sensor, not because the patient's sucking gas out of the control valve of the ventilator, because they're sucking gas out or maybe pushing gas into the compliance of the patient's circuit.
Wonderful. Better said could not be done. But the important thing here is that as you're controlling, remember, you were controlling flow, so your eyes should go and look at the pressure waveform. So just for the sake of that. All right, so what do you think is the load for this patient? And remember, we look at the inspiration and expiration. All right. I love this. There's a stream of PMOS coming through, and absolutely, there's a lot of PMOS occurring during inspiration. So that's very useful. I would also now let's focus on expiration, and then I'll make a comment about this. So during expiration, and what do you think is the load? Good. And I start seeing the elastic come out, and I would agree with this absolutely. So during inspiration, in 3 of the 4 breaths, you see evidence of PMOS. And we know that because we're watching the pressure waveform, and it's moving downwards. And the only way that that could happen is if there was PMOS. And then, but you do have a little fragment into passivity. And so if you look at the first breath, where there is square waveform, and then you come up, you'll see that there's an initial step up, which is relatively small, and then you can see the slope. So I would say that just remember that even though in the 3 breaths you can see PMOS is hiding the reality, but this is consistent with an elastic load, again, which is the common thing that we would see. And that is aligned with your thought that there is evidence of elastic load. It returns to baseline. Actually here it's very perfect, even below 2 seconds. Normally in a normal environment, it would end up in around 1.7 to 2 seconds. So that means that this patient has elastic, which is the normal physiology. So very good. Rob, comments?
Nope, that's perfect coverage.
Excellent. All righty. So team, now it's time for the patient ventilator discordance. So I'm gonna do something that we sometimes we do when we have too many waveforms. So I'm gonna put a number 1, a 2, a 3, and a 4. So what do you think is the PV discordance here? And we can start by the trigger and go at it from there. And I'm going to ask that you mute yourself if you're not muted. I can hear some background noise, just minimal. Jorge, I think it's you. Yeah, all right. So really, really interesting. I can see a lot of numbers coming through. Great job. So breath number one, I think we would all agree that breath number one is, first of all, we don't have the marker from the device, but we can see a very nice passive waveform. The pressure increases rapidly, and then it's constant throughout the inspiration, and then it goes back to baseline. And in the expiratory flow, we don't see any item. I saw Fernando says that there were cardiac oscillations, and I think that he's right. There's some noise there. But it's essentially a passive breath, the first one. And then we have our marker for the patient triggering. You can see it right there. Right there. That's the ventilator is saying that the patient triggered. And it's pink, which says that it's a flow trigger breath. And we can see the flow crossing baseline. And then in this case, we have actually the esophageal pressure for this patient. And you can see the esophageal pressure starts dropping right around that time. So this definitely looks like the ventilator is following and triggering at the same time. So I think breath number one, the trigger is, as many of you pointed out, normal. Rob, comments about that?
Nope, looks good.
All righty. For the second breath, for the third and the fourth breath, many of you highlighted that this was early trigger. And the way that it gets recognized without the esophageal pressure waveform, but just looking at the waveform, you will see that it's triggered by the machine. So it's time triggered. You can see that the rate is set at 20 breaths per minute. And the machine triggers the breath. There is no marker to say that it was the patient. And then little after, and so you have that little step up that tells you that this was not resistive, and then it starts going up, and you can see that it's identical to the breath number one beginning, and then it sucks it out. So if I had continued this waveform as it should have been, it would look like that. And so all this area is PMOS, and so PMOS that follows a mandatory breath is absolutely a early trigger. So the early trigger would be breath number three. And similar pattern you can see on breath number four. So so one and two, sorry. Oh my, I'm showing the future. One and two, very good. Rob, comments?
Nope, pretty straightforward.
All righty. Now, normally we would say, there's not much to see after that. You recognize that the rule of discordance is that we treat the first one we see. So you would need to treat this. But I thought that this was interesting too, because we rarely have an esophageal balloon with PMOS and looking at the work shifting context. So for a couple of seconds, just we recognize that this is early trigger, and you would treat the early trigger. And I can ask, how would you treat it? But before we get there, let's just for a second look at the amount of work shifting that occurs. And so if I draw again the waveform here for the other one, it would look like this. So that's all the amount of work that the patient is doing, and then this one looks somewhat like that. And so the benefit of this is that you can see how it goes below the baseline on breath number two and breath number three. And then on breath number four, it doesn't. And then you have the magnitude of the breath down on the esophageal waveform tracing. And so you can see on breath number one how the pressure is rising. So it should have rise like that, because that's the esophageal pressure is raised. The breath is increasing the lung volume and also transmitting to the pleural pressure. And so you see the rise on the pressure. And then when there's PMOS and effort, you can see that the pressure goes down, similar to the same morphology, if anything, as you see on the pressure waveform from the ventilator, you see how it mimics the waveform over here, and the same for the next one and for the last one. They are essentially, you're seeing the same deformation on your pressure waveform. Rob, comments there?
Yeah, the lower the esophageal pressure, the higher the PMUS. Right, so those little peaks are the lowest points in the esophageal pressure and the highest points in the PMUS, more or less.
Yeah, so you're talking about this delta.
Yeah, that delta, yeah.
This delta from here to here, and you can see how different it looks. And I find this appealing mentally, because many times we see the waveform up here, and you realize then how this tells you about the work shifting that is occurring on this breath, and it's complementary in this case with the esophageal balloon. It also helps me understand. I mean, you heard us say several times about work shifting, that the severe form, when you're generating negative pressure, and actually this one goes almost below, but it's dropping the pressure below the baseline. So the patient is getting less flow than it should for what the patient wants. Rob, comments?
Nope, that's exactly it.
So I would ask the team now that you have seen this, and again, you need to treat the early trigger. How would you treat this patient? What strategies are you thinking of as you see this? And remember, in the common literature, actually, this pattern is very consistent with reverse trigger. That pattern triggered by sedation, awakening on our patients, highly common in our ICU. So I see already Simran and Trish said, stop the sedation. And then Alicia comes in with a punch. And I love when Alicia comes with the punch. She says, Eduardo, what's the goal? And Fernando comes second, saying, depending on your goal. And that's absolutely right. And so this is an important thing, because if your goal is safety, then the question is, well, can I let this patient be awake and breathing on their own? And if the answer is no, because I cannot tolerate, and I am afraid of lung injury, or they cannot maintain their gas exchange is essential, then sedation or returning to sedation may be the way to do. But I would highlight that just looking at this pattern, and in the absence of Armando to give us context on this patient, I would say that with 35% oxygen, 6 of PEEP, this patient likely could tolerate a drop in rate, which would be our first action. There's other alternatives. I saw the decrease in sedation, decrease in respiratory rate. Any others that you can think of that you could consider in this type of patient? Anybody else? Yeah, so pressure support is also PCCSBS, as Alicia is putting. Changing the mode, Trish said, increase the inspiratory time. Increasing the inspiratory time is not going to take it out. It may hide or avoid double triggering. Jerry says, trial of SVT. I love how you're thinking, because it all depends on the goal, right? So if this is a patient that you're waking up, you're now coming up to or you're thinking about extubation in the nation. This is a patient in which an SVT makes complete sense. And you'll see that, at least in our practice, and now that we're using modes that are aligned with the transition points of patients. So when the patient is waking up and we're thinking about an SAT, or we're performing an SAT, having modes that allow comfort, and so transition to spontaneous mode automatically are positive. Roberto?
Yeah, that's great that the audience has basically covered the full range of correct answers.
Yeah. So this is collective knowledge, and so all of us working as a team can solve it. I love it. All righty. Now, so Armando kept sending me images, so I thought that I would send a continuation of this case, just a little bit, because it shows a little bit of what we're talking about. So what I would ask you to do is, we're gonna in the sake of time, we already all agree that this is BC-CMB. S. And we talked about the loads, that it was PMOS and elastic. And during expiration is mainly elastic. But I think that the interesting thing is to look at the waveforms per se. And I thought that this was good because it talks about timing of events. So let's look at, and again, I'm going to name the event. So this is breath number 1. Breath number 2, even though it has 2 on its own, I'm going to call it breath number 2. And I'll explain in a second why. And this is 3 and this is 4. So again, we have 4 breaths. The rate is the same settings. Nothing has changed. It was just Dr. Rios was standing there with the camera taking pictures, or with his phone. You can actually see a little bit of his silhouette there. So so I'm going to go in order. So breath number 1, we know it's volume control. Do you see PMOS or not? Yes or no? Yeah, and that's what I thought that you guys were going to say, and I love it. So, oh, there you go. Arcel to the rescue. Yavira comes. So remember, we had the other breath, and this is very relevant. So remember that in volume control, unless you had a pause, these should look, and actually you have the cousin over here. You should see this go all the way up, and then this one down. So the tip is amputated. And so that's evidence of PMOS. And if you come down, forget about the flow for a second, but there's another hint. Yes, Megan, actually, you see this. You see the little dip over here that the patient is sucking from the circuit air. But the other guide is that if you look at the expiratory flow, instead of looking like this, you see how this is missing. And that tells you that the patient is doing inspiratory flow during that period of time. Now, and I like this because it shows how the esophageal pressure is different. So you see the esophageal pressure rise, and then there's PMOS, but the PMOS is above the pressure rise, so you don't see it dropping below the baseline. So this waveform, and I'm going to just go back to the prior one because it shows it very nice. So you see how it would have looked if it was passive. So it would have gone all the way up and then it decays, right? And instead of that, we are missing that rise and then the decay, and all this area down here is the PMOS. Okay. So this is early trigger, but it's hidden a little bit because you're used to it, to see it at different times. Rob, comments?
That's beautiful graphics there. I like
Yeah,
that.
so, and this is not an early cycle, Fernando. It's an early trigger because it's triggered by the ventilator. Okay. So breath number 2, do you see PMOS during inspiration? Have no fear. You can do this. Breath number 2, do you see PMOS during inspiration? And I'll explain in a second, Rowdy. So it's an early trigger, not an early cycle. It looks like an early cycle here, but it's triggered by the machine, so it cannot be an early cycle. It's an early trigger. So if you look at breath number 2, during inspiration, it would be hard for me to look at the PMOS. It's hard for me. Now, I suspect that probably right here at the tip, it occurred, but I can barely see it. And then the machine is telling me that it was triggered by the patient. And then you see the second breath should look actually like this, like that. And instead of that, you see that episode of the pressure going below. And then if we go down, you see how the pressure was rising up as expected because it's a passive breath. And then at the end of it, a little bit after, it starts dropping. And now it does drop below the baseline. So all of this area down here, all of this area is PMOS. It's higher than the baseline, but it's because we were at the end of a breath. So, and then it triggered another one, and now you have a double trigger or multiple trigger due to an early trigger. And this is an area of controversy or of thought process as we are trying to put nomenclature on stuff, because essentially this didn't happen during inspiration, but it happened immediately after expiration. And so it's a source that, I mean, we have to come to terms. Yes, Ariel, as we mentioned, this is also known in the literature as reverse trigger. So but this is useful also because I want you to observe what happens here. So notice a couple of things are happening here. The first one is that the slope is more there's more inclination, and the end inspiratory pressure is higher than on the prior one. And if you come to see on the transpulmonary pressure that is calculated here, you can see how the lung is being exposed to a higher transpulmonary pressure because you delivered, instead of 320, you have delivered essentially double the amount within 2 breaths. So you're over distending the lungs. Rob?
Yes, and the digital display of the tidal volume doesn't indicate that there's any problem.
Correct. Well, there's no alarm that comes to say that, right? So opportunity for improvement without a doubt. Now, breath number 3, do you see PMOS? Now your eyes are really starting to see like there was no tomorrow. So again, you see a passive start, the little step up, then it starts going up, and then all these areas amputated. And again, if we come down here, you see that we were going up, and there's some PMOS there. So the PMOS is this area over here. Not huge like others, but it's enough to cause the formation of the pressure waveform. Now it's not asking for more flow, it's asking for flow, and it's getting flow, and it's above the baseline, but it's not dropping the pressure below the baseline. It's close, but not. And the last one, but not the least, do you see PMOS? And yeah, now by this time, your eyes are master of disaster, and there is no question about that the end of the waveform is amputated, right? So you see, and so you see here in this strip of 4 breaths, different timings at which the early trigger can occur. Later on the inspiration, immediately after expiration, middle of the breath, and again at the end of the breath. And in the prior one, you can see it even earlier than that. So this just talks about these different phenotypes or that are being published about early trigger. And some of the comments that you will see in the literature is that these will generate different levels of injury. In some cases, it may be protective. In some cases, it may be detrimental to the patient. And yes, I love, Ariel, what you're saying. Yes, without a doubt. And we mentioned this on the first item, is just be careful, because this may make you think that this is dual targeting, because you're going to see abnormalities on the flow, but you can see the pressure waveform and just knowing where the trigger. And actually, I would also highlight that that's important for you to use our app with the tags, because this has been vetted by Rob and Ping Lee on what is going on with these patients. So I would just highlight the key findings right now is, one, we reviewed the different manifestations of early trigger which in this case, the cause of the early trigger was reverse trigger. We also talked very nicely about how to treat this, and we talked that the thing that drives us in the goal-directed ventilator management is the goal. And so defining what your goal, if it's safety, comfort, or liberation, will define how you are going to move about with this. And we heard from everybody, from going to sedation, to changing the mode, changing the rate, to doing a SBT, or spontaneous breathing trial. And so finally, the take-home message. Oh, and finally, the other item is not to confuse this with dual targeting, that this is a proximal sensor showing that. Rob, moments of truth, a Zen moment.
No words of wisdom. That's covered very nicely. There's a question by Karsten, though. You see it?
Yeah, so sorry, did you talk about the diaphragm trigger? Yeah, yes, we talked about that, Karsten. So thank you for it. So I would just leave you with a thought process here, which is the esophageal balloon is useful to see this, but you need to know what you're looking for. But you can see how the waveforms are telling the majority of the story. So we wouldn't have needed the esophageal balloon, but it's good to have it as a training visual of what the PMOS actually is doing. And that's something to be said about it. And there's actually a paper demonstrating that when you put in a AI-induced waveform that looks like PMOS, it helps people recognize those interactions better. So here are the CME for the caregivers. So that's the code. Put it in and you'll get some a CME for being part of us. And then CRCE for the RTs. Remember to register for the SEVA program. There's opening still, although we are at 60% of capacity. The 60 slots, we're I think at 42. So please log in for the April SEVA Summit. There's prior episodes on this QR code. And as I said, we welcome you on all of this. So thank you for the happy 100 SEVA online. We love it. And thank you all. Thank you, Rob. Have a wonderful day.